Okay, so welcome to our 11:15 plenary session, measuring the usage and maturity of the interoperable EHR across Canada. So I'm Jim Mickelson. Those of you who were here yesterday will remember me from the morning, but I'm the local Infoway guy in Vancouver, executive director for all of our operations across Western Canada, and I have the privilege of moderating our panel this morning. So the focus of the panel this morning is around both the past, but more importantly the future, EHR adoption. We've got speakers from 3 different jurisdictions and looking to have some discussion around the future and the innovation that will be built on with current EHR adoption. So our panelists today, we have Simon Hagens, Director of Benefits Realization, Canada Health Infoway. He'll do some setup in terms of a national picture of EHR adoption. We have Susan Anderson, formerly ADM, Alberta Health, now with Orion Health. So we'll give her a particularly hard time for moving over to the vendor side from the public sector side. Perry Poulsen, Chief Information Officer from Manitoba eHealth. And sitting in for Laura White, who unfortunately came down with a very bad cold, is Gordana Dulovic, Senior Manager of eHealth with the Provincial Health Services Authority of BC. And so with that, Simon, I'll ask you to start us off.
Okay, thanks. All right. Well, I'm very pleased to be able to set the stage for this panel and talk to you a bit about the adoption and benefits we're seeing so far. Lots of talk so far about the foundational elements and the iceberg as it's been described, and exciting at this point in time to be able to tell a really good news story about this and really demonstrate that iceberg is slowly but surely rising, and we're seeing the value coming from it. So I'm going to start with just a quick view of what the electronic health record is, just to make sure we're all on the same page. There we go. So, this is, as I'm sure we're all aware, the longitudinal record of patient information. So we're talking about lab, drug, DI, clinical notes, available in an integrated view for clinicians across the continuum of care. We take a measurement of the adoption of EHRs pretty seriously and have been looking at this over the years. We have a concept of an active user, which is a user of multiple clinical domains in a single view. And over the years, this has increased dramatically. So we're now, as of January 2015, over 90,000 active users across the country. And as you can see, growth in the last couple of years, really substantial, which is exciting to see. Another view we take on this question is by asking clinicians and others about the access to information that they have from any systems that are beyond their setting. And when we look from that perspective, we see about 250,000 users respond that, yeah, they do have access to some information sources from outside of their care setting. So we're seeing that use expand. We often get the question, what's the denominator for this number? Right now, with the current sort of deployment approach that we've got, we're looking at around 500,000 is the number of users that we would expect to see in Canada in the near term. Obviously, though, as these solutions expand and allied health professionals, other kinds of professionals, and ultimately Canadians involved, we would expect to see much higher numbers. And we'd love to be able to talk about 30 million users in terms of Canadians. So I'm going to dive a little bit into some of this data. We look at per capita uses to get a sense of where different provinces are at. And not surprisingly, this very much correlates to the length of time that these provinces have been using these solutions. So in Alberta, who's been on this journey for over 10 years now, the highest per capita use in the country, and really still a substantial portion of that 90,000 users that we have today. But these other provinces that are creeping up quickly, Nova Scotia, Manitoba, BC, all sort of around 5 years that they've been substantively adding users to the base. And then we have some of the newer provinces towards the bottom. When we look at the growth rates, BC's arrow seems to have disappeared. Let's see. Oh, there it shows up. Just a late arrow for BC. Well, when we look at the growth rates,
later,
yeah, that's got to be it, eh? we see that Alberta is starting to plateau, so they're in between the 5 to 20% range for this year. That's what we're estimating we're going to see this year. Still really substantial growth in some of those provinces that have had those solutions around for 5 years. And for the newer provinces, Quebec, New Brunswick, Newfoundland, between 50 and 200% growth. So even though these solutions have been around for a while, realistically, enormous growth rates in terms of utilization. So we're seeing big growth from deploying to new settings, new user types, and integration is a huge driver of that growth. So really exciting to see. And talk for a few minutes about benefits. So we've done a lot of work over the years to try and understand what's the value proposition of EHRs. We have a reasonable amount of evidence in hand now, and a lot more coming in the next year or two that really gives us a good sense of where we're at in the journey. And we really see that this is a journey. This is about a maturity curve. Right now, where we are, for the most part across the country, is in this early benefits phase. We're filling information gaps. And we've had lots of good talk about that the last couple of days, lots of great stories about that critical nugget of information which is now available that was not there before, and the value that can add for patients, the value that can add for saving time. But we really want to continue moving up the curve. We see big efficiencies as the next spot in the areas that are more advanced. We're seeing some of those efficiencies. Things like workflow analysis, integration of solutions are really key components to generating those medium-tier benefits. And then the longer-term benefits, obviously, are the ones that we're all seeking from the electronic health record. And these really require things like the more advanced functionality, decision support, kinds of things like that, and analytics, of course. So even though we've been on this journey for a while, we see that we've still got a ways to go in terms of achieving the value. So the last thing I'll share with you is some of the data that underlies this. A study that we conducted last year looking at information gaps and the consequences of those information gaps. And this was a study of ambulatory specialists. So we had a cohort that have access to electronic health records or their components, and a cohort that don't. And we asked them for a series of 100 encounters to provide that information. So a good sample, 1,800 encounters in total, looking at what happens. So for those unconnected physicians, the docs that don't have access to that information from other settings, what we see is they frequently have to reorder tests. So 5%, 3%, not big numbers. When you think about that there's something in the range of 44 million encounters in a year, suddenly these numbers start to be pretty significant in terms of costs. 1 in 10 times they're saying, I'm wasting my time, I'm wasting my patient's time. These are on each encounter basis. So 1 in 10 encounters, they're wasting their time or their patient's time because of information gaps. And disturbingly, from a patient safety perspective, 13% of the time they're saying, I had to move forward with this encounter and I didn't have the information I needed. When we look at the connected side of that story, those docs that do have access to those solutions, we see significant drops across the board, significant improvement, and especially, really nice to see the force to proceed with incomplete information dropping right down. So for me, this is a glass half full story. We've made substantial progress. We're seeing substantial value from those investments, but there's also a lot of room for improvement. This is a published study, by the way, so you can find this in the Journal of Medical Information Research, and I'm happy to provide that link to you. So that's my portion of the story, and I look forward to hearing the discussion on where the benefits go from here.
I didn't really want to stick with my slides. I think a lot of what we've heard over the last couple of days, there's a common theme about what we're doing here, and I really appreciate the opportunity to participate. I've always found these so much value out of these sessions because I can take home some of the messages that I hear about. I know a lot more about icebergs and more is less, less is more, and a little more about not lab testing but wine testing. So I'll take that home with me. I'm sure everybody will be impressed. I always come home with a fairly good story. But I think that, are we there yet? And it's funny, we get asked this question a lot. What's it look like when we're done? And it's a really hard question for me to answer because I don't think there is an answer. When new opportunities for interoperability present themselves, we want to take advantage of those. And I think part of what we've talked about, and I think we've been on this journey for a long time, and I think everybody's saying the same thing, what's taking us so long? And as much as I'd love to think that we can move along faster, the complexities are there. So, Are we there yet? I know it sounds like we're whining, but there's a lot of excitement behind what's out there because we want to incorporate that. We want to make that part of our plan. In Manitoba, some of the nice things that have been happening is we used to have 11 RHAs, now we have 5. I think Manitoba is situated really well in the sense that we can start to drive out a common ICT strategy. We also have the opportunity to drive out a common enterprise architecture for the province. And when you start talking about getting rid of some of these barriers and collapse some of the complexity, this is around choices and making choices around the systems and the sources that we choose to put in our EHR. So I think it's not just about making those choices about what those systems or source systems are, it's about how we're actually going to integrate those as well. So we have adopted a common integrated platform for driving our connectivity. You'll see on the left there that we've got a number of source systems that we've chosen to put in to the system today, and I don't think they're anything of a surprise. Most of us consider those as what would be the norm. Certainly we want to add to that pathology reports. We've got some initiatives around an image viewer, and adding discharge summaries, because I think they're where we're going to go, and this is where we're going to increase our adoption. I think the other side of that is, this is a viewer, and we have to recognize the fact that it is a viewer, but I think that the value of that and providing a common access point where people can get a view of the information they need is where we're seeing irreversible momentum around people adopting the product itself. So we actually have 15,000 accounts, and we have a monthly usage of around 5,000 clinicians. We've done a number of surveys. We get good, I'll call good feedback. There are still some things that people would like to see us enhance. Certainly for us, part of the challenges, and I know some of that's been addressed today, and I'm interested to see where we go with the, I was in a session yesterday around privacy and information sharing agreements. Certainly I sign, it feels like hundreds a week. I sign an agreement depending on who it is and what clinic it is. So those are going to continue to be a challenge. And in those agreements, of course, there's all the discussions around audits, who's accountable, how many samples do we do, should we be sampling more? I think the other challenge that we have really is around when we add more source systems and we start to do upgrades, enhancements, and so on, we need to have some quality assurance that the information that we're presenting is not just the value, but quality information, and it's the right information. Adoption. So we've talked a little bit about adoption. I think it is taking flight. Some of the new pressures that we're seeing is and interest, which is exciting for us. Certainly with fire paramedics now want access to eChart. Corrections or the justice system wants access to eChart. Pharmacists, they all see value in the information, and we're just trying to figure out how best we actually get them on board. Typically, they're not sitting in a hospital or a primary care clinic, and so we're going to have to work around that, and certainly we want to make sure we have a mobility strategy that meets the needs of those individuals who are going to use those systems. I think error reduction, and I think it just goes back to the earlier comment, really it's around quality of care, and so we know that we can find gaps, whether that's gaps in immunization. eChart actually has the ability to trend lab results, and it also does that across multiple labs. So information that typically people wouldn't see just because they're in a hospital, we can actually pull lab results from many different lab sources and pull that together to be a positive impact for people who are looking up, and it goes back to saving time, gaining access to the information that they need to manage their patients. And I think that goes back to the efficiencies, and it is really around the ease of access. And I think the other efficiency there is it diminishes the requirement for double testing and looking up and x-rays and so on. So we've seen a lot of benefits come through the product in that sense. I think the unexpected value that we're seeing now, and where we're, I'll say, making a change to our strategies to say, is there an opportunity for us to use this as a downtime system? So I don't know if anybody's really looked at the risks that we have. We've got so much more information than we've ever had before. The dependency on the information, the primary systems that we have, is becoming so much more critical, but we still experience, even this weekend coming, we have a 15-hour outage for a PACS upgrade. And people get very nervous about when we start shutting systems down for 15 hours. And what do we actually, do we have an alternative to give them? And I think eChart actually gives them a valid way to look around, at least within a short period of time. If they really needed a system to look up patient information, I think there's a good opportunity for us to look at something like we've done with our viewer. So where are we going? I think that we need to integrate and go back to the interoperability. How do we make this seamless? And can we actually take eChart now and put a hot button into our primary services? We've done this already. We've started to do this already. We see a huge benefit for people using the system. It is that, I think really what people are gravitating to is that one-stop shop. They can log on. They don't have to search around many systems. We still have 300 applications. We're slowly whittling that down. I'm glad to say that. And I'll echo the fact that, you know, as much as we're working at that at a provincial level, we know we need to do that across our jurisdictions. I think in 10 years from now, the discussion won't be about what we're doing in the provinces, but what we're doing across the other jurisdictions. We're talking about the multi-jurisdiction pathology service that we're trying to get through. I don't want to pick on the privacy analyst, but she's probably here somewhere. But we're trying to work through those agreements to say how can we deploy some of those services across Canada. And it's really exciting, and I think that's really where we're going to start to get to. So, and I think the other part, when we start to build these, and I go back to the comment about how we build them, we're certainly using the Infoway maturity model for interoperability, and we're trying to build towards that. Interoperability is back into our strategy, is a strong point where we're driving. And we're leveraging that and the technology of how we've actually even built eChart for things like consumer health strategy and all those other new projects that we're working on. So are we there yet? Well, I have to say no. Are we on the right track? I think we are. But I really feel that we've really just begun. So thank you very much.
Good morning, and I'm here to speak on the Alberta Experience. I'm currently now living in Ontario, but my time in Alberta closed out roughly about 3 weeks ago. So I feel like my memory's mostly intact, and I'll share some of the perspectives around the Alberta current state, future state in terms of the direction around electronic health record. Just a few statistics up front. Today, we say that the electronic health record in Alberta, which is called Netcare Electronic Health Record, has approximately 50,000 active users. And on any busy day, there's about 5,000 concurrent users and roughly 2 million, close to 2 million patient accesses a month on a regular routine basis. So the clinicians in Alberta would say it's a critical component of the clinical system environment today, even where they have their own electronic medical record or hospital-based clinical information system. Netcare plays a key role in the supports for the clinical care. And let's see, we'll move ahead. And I have a very short video here that's just 1 minute, just to give you a little bit of the history background.
In 2006, Alberta Health Services chose Orion Health's clinical portal for a province-wide electronic healthcare record due to the scalability, configurability, and ease of use of our solution. Since initial implementation, the solution has been upscaled to include additional rich patient information. In 2012, e-referrals were added, making the Alberta site Orion Health's largest health information exchange customer in North America, servicing a population of nearly 4 million. The solution has had dramatic results.
So that gives you a sense that Alberta's been on the journey with electronic health record for a number of years. We say as of January 2008 was really the key milestone in terms of a date when we would say provincially every Albertan had an online longitudinal electronic health record. And that record has continued to expand over time, as has the number of users and the types of users to adopt. This slide just highlights what we're calling meaningful use journey in terms of Alberta, and the arrow at the bottom sort of indicates that Alberta being still at the level 1 around data capture and sharing, but I think I would today would move that slightly to the left in terms of saying we're Alberta's achieved some capabilities around advanced clinical processes. It was interesting reflecting on the keynote speech yesterday from Cleveland Clinic and some of the parallels that I saw in terms of the capabilities that they offer, both on the clinical portal, but also on the patient portal. So one of the key areas in that level 2 maturity is around the engagement with the public and as consumers of health, as patients, on both their own personal wellness journey and then the direct engagement with the health system. This is an area that Alberta, with the support of Canada Health Infoway, has made significant strides in terms of investment, bringing forward first production portal in 2011 with access to knowledge and services, starting to do some very interesting interactive capabilities in 2014 around organ tissue intent to donate registry, and then just this year stepping into some of the more advanced capabilities. Similar technology is what Cleveland Clinic's using with the Health Vault platform for pre-EHR, but also enabling access to some other applications that have very strong capabilities, such as a tethered portal into a clinical information system, and limited production rollout that's happening right now in the Edmonton zone with the Epic eClinician application. So very similar capabilities. We don't have the support of the second opinion as Cleveland does, but I think that's an intriguing concept for not just Alberta, but Canada in general, as we step forward in terms of empowering the public around education and empowerment engagement, and giving them the tools to have a more interactive, participatory role as a member of their care team. In moving towards a level 3 of an improved outcomes, I think this is a desire of Alberta, just as it is with all of the jurisdictions across Canada, that we want to move beyond, for example, in our focus on fee-for-service type engagements to look at more meaningful outputs and to have the mechanisms to collect the data and to capture information in support of looking at what's the impact and the value to the patient, not just are we gaining some efficiencies, effectiveness for the health delivery system. And in terms of looking at the future, this slide highlights continued focus around interoperability and exchange of information. Alberta's got a number of over 2,000 systems that are part of the electronic health record structure. There's some basic system-to-system messaging there, access to drug profiles, starting real-time updates from the pharmacies into the drug information. But we're just on the front edge in terms of some real significant system-to-system type exchange, what I call intelligent integration capabilities, and focus, for example, around some advanced capabilities such as electronic referrals that is accomplished today through, there's limited production rollout of electronic referrals on the EHR portal supported, and that work will continue. And then I mentioned the consumer health side, and interesting comments to see that steps happening in the US where some of the patient-contributed information perceived as having value and could be integrated at the electronic health record or possibly even in the clinical information system. And then focusing on quality measures in terms of driving quality. We see a stronger emphasis around in Alberta around the focus on secondary use and recognizing these long history of repositories hold a lot of valuable information that contributes to the analytics capacity from a secondary use in conjunction with new data sources coming in through big data, et cetera, and the technologies to bind those pieces together. So I think the one added comment I would make in terms of going forward in the future around electronic health record is that the types of users of the EHR are going to continue to expand in Alberta. We're seeing new types of what we're calling authorized custodians coming into view. And just some examples, optometrists who are ordering lab tests now, opportunity for them to come on as authorized custodians in their teams. Dentists are another prospect of a group. The chiropractors, physiotherapists, midwives. So there's a number of new players that are coming on the scene, and with them they'll bring new data sources along with that to complement the data that's already there. Okay, thank you.
As Jim mentioned, I'm stepping in for Laura White on a very short notice. My name is Gordana Dulovic, and my team at PHSA, Provincial Health Services Authority, develops and supports a number of eHealth solutions, including CareConnect, the provincial eHealth viewer, as well as PLIS, the provincial lab repository, and then the HIAL, which is the health information access layer. Back in 2009, the province adopted CareConnect to become the provincial eHealth viewer. Up until then, it was a regional electronic health record. And since then, we onboarded a number of provincial eHealth domains to CareConnect. And we also deployed it across all of the health authorities in BC. This diagram just shows the data available within CareConnect today. There are components of the shared health record, encounters, documents, etc. And then we also have all the provincial labs from all the health authorities and private labs through Accelerus, and all the public digital imaging. This table shows the number of users, registered users within CareConnect. We're currently sitting at just over 38,000 registered users. But you can see the breakdown by health authority and over the years. In terms of active use, and this is an interesting slide, as we added those provincial eHealth domains and deployed to all the health authorities a few years back, the use has grown significantly at a fast pace. In the past year, it slowed down a bit. It's still growing, but it's slowed down as the viewers become more stable and there were no large deployment efforts. But what we've seen over time, analyzing our stats, two of the primary drivers for increased adoption are either adding new significant data to the viewer that's valuable to our clinicians, or significant change management and promotion effort. This is not a mandatory system, and we find that even after years of being deployed in certain areas, as there's a turnaround of users and people don't know about it. And then when they suddenly find out about it again, they're surprised by the value it brings. So change management effort, clinical change management and promotion was significant over time. I'll just leave it at this slide. So this is where we came from. In terms of where we're going, interoperability is the focus and has been over the last couple of years. It's continuing to be. We have the viewer deployed within core clinical systems within health authorities or as a standalone, but it needs to be, the information needs to be more seamlessly integrated into those workflows and clinical information systems that people use on a daily basis. So there's a number of efforts within BC for that kind of seamless integration. For example, Fraser's Health Authority is integrating directly the PLIS data domain, the labs within their UCI system. We're in conversations with Island Health to integrate more seamlessly using some of the back-end infrastructure of Care Connect rather than launching the whole viewer within their system. We have a number of initiatives within Vancouver Coastal Health or PHSA integrating either data services that Care Connect provides into, for example, a Vital Hub solution that's a mobile viewer for PHSA, or integrated pieces of the Care Connect screens, those portals, within other point-of-service systems to simplify their integration efforts. Another area of focus and an opportunity is access outside of health authorities. Currently in BC, the eHealth data is available only to predominantly only to health authority affiliated clinicians. There is a huge opportunity for those other groups that are not affiliated, private physicians, specialists, chiropractors, physiotherapists, etc. There's over 40 groups that we've received requests from. And obviously privacy processes would need to be established for those. But we have a couple of projects that are paving the way. One of them is granting access to Canadian Blood Services to the PLIS data. And this is in partnership with the government of BC, their MTech group that supports the BC Services Card. So this will be the first implementation that leverages two-way authentication that BC Services Card, which is a care card and a driver's license in BC. And they have this functionality that hasn't been leveraged yet. So we had a successful pilot federating BC Services Card, and this is a stepping stone potentially for patient portal as well in terms of a solution for authenticating patients. For patient portal, the ministry is working on a strategy overall for providing access and authentication. In the meantime, there is patient portal within Lower Mainland provided by Acceleris, leveraging their results distribution solution. And we had a pilot with Children's Hospital and BC Cancer Agency for their patients to view transcribe reports. So labs are already available to public in BC through Acceleris, but transcribe reports are now next. Another initiative, I was showing data available within the eHealth viewer. The SHR, Encounters and Documents, access is not complete, and we're working, hoping over the next year or so to complete that record, getting access to other health authorities that are currently not participating. Some of the challenges that we've overcome, obviously privacy challenges within having all those separate health authorities. There's information sharing agreements, but there's other privacy challenges that still need to be overcome, those processes to establish for non-health authority use, and also to do with secondary use. There is no clear processes right now to enable access for research or data mining, and also, yeah, for non-health authority access. Another challenge that we've overcome is understanding that Care Connect is not just the viewer. And we started over the last year leveraging its back-end functionality for interoperability and for simplifying that access for point-of-service systems to those domains that we already conformed, connected with the HILE, which is quite complex. Another challenge that BC is facing is the HILE, Health Information Access Layer, has been in place now for a number of years, almost 10 years, and it is getting old, and it is cumbersome and very difficult to work with. It provides a big challenge to a number of eHealth projects right now in the province. Just checking my notes. I think I covered most of the points. I'll stop there. Thanks.
Thanks, Gordana.